We are live, sir. We can go ahead.
Yeah. Good evening, everyone. Today we are having the Grand Rounds Series 2, and we have none other than Dr. S. Rajasekaran. I don't need to introduce Dr. Rajasekaran, as we all know, the man who has changed the interface of Indian orthopedic and spine surgery worldwide. Dr. Rajasekaran is currently the president of many societies, but currently he is the AO Spine chair for the world. And we all know he was the ex-president of Association of Spine Surgeons of India and many other societies like EASLS, the CSRS, and the IOA. We welcome you, sir, for having the rounds with you today. At the same time, we have the International Master of Indian origin, Dr. Ajay Joshi. Dr. Joshi is working presently at San Antonio in the medical hospital as an associate professor and director of spine surgery. And his work on minimal invasive surgery and pediatric deformity is incredible. We welcome you, Dr. Ajay Joshi. We have my colleague, Dr. Abhay Nene, for comparing and moderating this session of rounds today, where we will be going one by one with the case, and we will take from the stalwarts how they will approach this case. There is always a dilemma in spine surgery. Nobody is right, nobody is wrong. We need to see how these legends speak and what really they will do in these kind of scenarios. We will be keeping some interesting cases too today. This world is supported and affiliated by Maharashtra Orthopaedic Association, Pune Orthopaedic Society, and Sancheti Hospital. I would like to invite President of Maharashtra Orthopaedic Association, Dr. Ajit Shinde, who is giving us incredible support for this kind of academic activity. Over to you, Shinde, sir.
Good evening, dear friends. On behalf of Maharashtra Orthopaedic Association, I welcome you all in this fantastic webinar with world-renowned spine surgeons. Before I begin, I would like to extend my healthy wishes to you all and your loved ones. We have none other than Dr. S. Rajasekaran, ex-president of Association of Spine Surgeons of India, who is legend himself, and many of us aspire to be him. Sir, I am great admirer of your work, and I always look up to your lectures, be it academic or spiritual or anything, as they inspire me to become a better surgeon and person. And I'm sure many of our viewers feel the same. We also have Dr. Ajay Joshi from Texas, who is an international spine master and deputy editor, clinical spine surgery. We have brilliant spine surgeon duo, Dr. Shailesh Hadgaonkar from Pune and Dr. Abhay Nene, Mumbai, as a convener for this program. I believe many of the spine patients are deprived of medical care because of lack of resources, especially in peripheral part of India. Majority patients being to lower socioeconomic strata and lack of educational or financial constraint make them difficult to reach to a proper facility center. I request, sir, we have learned about your effort for needy patients. I request you to guide all our national as well as state level orthopedic association to come up scheme or policies in association with government to manage such a patient. I also congratulate Dr. Sham, our convener, for organizing this webinar. My best wishes are with them, and I request Dr. Shailesh and Dr. Abhay Nene to take over now. Thank you.
Thank you, sir. Thank you for your kind words and great support. I would really like to thank Dr. Ashok Sham, Dr. Neeraj Bijlani from OrthoTV and Indian Orthopedic Research Group for incredible support for this world premiere, as today's program is premiered in many countries across the globe. Thank you, Dr. Sham. And at the same time, I would like to thank Dr. Himanshu Kulkarni, who is a spine surgeon from Sangli, will be coordinating with us for any questions or anything for Dr. Rajasekaran and Dr. Joshi. We have displayed Dr. Kulkarni's number on the brochures. Over to you, Dr. Nene.
Yes, thank you so much. And in keeping with, you'll have to stop your screen sharing. Yeah. in keeping with the pulse of this program, this is going to be a grand round, which means that we have two senior masters with us who are with us on a round, and the ward is full of spine patients of varying etiology, and we need to pick their brains on how they would want us to handle these patients, including how to go forward, what planning, operative or conservative, if it's surgical, what tips and tricks the registrar should know, and where they need to come in. And we've chosen two gentlemen who obviously need no introduction, but they have astounding work ethics. They're known across the world for their work ethics, and hence all the information that you're going to get from from the next hour and a half is going to be very, very medical and very, very non-commercial. So over to the first case, gentlemen, thank you. This young lady is lying in bed for the last 2 days, admitted herself because she's got another bout of a locked back, and she's been getting these bouts regularly. And each time she takes some medications, and in a few weeks she's all right. But now she's, at the end of her wits. She's disabled. She has no neurology. There's a lot of paraspinal spasm on examination, and she's just lying in bed like that. In this manner. This is the X-ray and the MRI that we'd like to show you, sirs. Dr. Rajasekaran, anything odd here? Anything that doesn't fit the bill? Or is it a standard run-of-the-mill case for you?
So, Abhay, this is a 38-year-old lady who should be in fitness of health because she has got a long life in front of her. So, you mentioned the terminology recurrent attacks of locked back. And that word is typically used for people who are having an instability. And she's also got a back pain, and she's got bilateral lower limb claudication for 3 years. X-rays are very characteristic. I think it shows a L4-5 lytic listhesis bordering between grade 1 and grade 2. There are no stress hysterics here, but obviously it's a case with a lot of instability. And MRI also shows that there is a listhesis, there is a degenerate disc at that level, there is a pseudobulge, if I think I can call. The foraminal level cuts also show some compression. So it all fits into the bill of having a L4-5 lytic listhesis, instability, and also there is both the foramens are closed. So
it explains the recurrent attacks as well as the radiculopathy. Ajay, can I get you in and ask you how common is L4 lysis? Like, do you see that as often as you see L5 lysis in your practice?
Less common, and this may have been someone who was a adolescent hyperextension athlete. We think of butterfly stroke swimmers, offensive linemen in our American football culture, gymnasts, etc. But L4 is not infrequent, but most frequently we use the L5.
So do you think differently if it's L4, or it's the same pattern of thought process?
At the lysis level, same pattern and thought process. I think the L5 lysis treated earlier for trying to heal a spondylolysis would be important to add a thigh extension on a brace. Often we see someone who's not treated with the thigh extension. So I think that is important at L5, but same principle at the lysis stage, probably same principle at the listhesis stage as well, L4 or L4.
Dr. Rajek, and the GP who referred this lady who's admitted now said that this is a birth defect. She was told it's a birth defect. Would you concur? Because she's been asking us that am I born with this?
Well, I mean, there's such a lot of talk that it's a developmental anomaly. I wouldn't say that it's a birth defect. So when you term it as birth defect, then it becomes a congenital anomaly. So lysis in particular is not it happens during the adolescent stage, but I wouldn't term it as a birth defect.
Right. So going forwards, this is a stress MRI, stress X-ray, as you probably would want it. Do you think, sir, this is unstable? Would you consider this radiologically unstable, or what's your interpretation of this radiological finding?
You're not able to see a massive change, but that doesn't preclude this case being stable. I certainly won't call this as a stable spine because there is obviously a gross displacement, and it's a chronic one. So sometimes you are not able to see a lot of instability, and this could also sometimes be due to a lot of muscle spasm and the patient is having a lot of pain.
Right.
So I would easily treat this as, consider it as an unstable spine. Apart from just the typical things we talk about of how much it actually translates and how much it actually angulates, you have to look at other subtle signs. So if you see the L5 vertebra, the anterior-superior corner, in all cases where there has been instability, you will always find there is a small notch. That is a small slump. Yeah. And that typically comes when there has been a lot of instability. That's a very important sign I always look at to notice whether there is instability. And you will also see in the lower part of L4 on the anterior side, you're also having a typical spondylophyte, which also indicates that this is an unstable. So maybe it is not showing a dramatic instability, a great movement, but this could be a lot of spondylosis. Maybe, I'm not sure, if you look at it carefully, there is probably a vacuum sign at the posterior corner of the disc space of L45. And vacuum
right
sign,
there.
Right there. And a vacuum sign is a definite indication that it always occurs when there is an instability. So it's definitely an unstable situation.
Right. Ajay, can I get you in here? Because the Americans gave us, the White and Punjabi gave us the actual data points of instability on radiology. And many of us go home thinking that if those data points are not met, the spine should be considered unstable. For example, here, the angular instability doesn't seem, more than the proverbial 11 degrees. So can you give us your pearls on this, like clinical instability versus radiological instability? What would make a bigger impact in your planning for treatment?
That's a great point that, there are some formal prior measurements. And to be honest, in practical terms, I don't typically look and see, is there greater than 11 degrees of change on a flexion extension? There are times where a millimeter may be more valuable, so to speak, or more meaningful than other times. So I wonder, it'd be interesting to ask Punjabi and White if they would revise that for 2020. Nevertheless, clinically, she's having these attacks recurrent. I think, just to digress for a moment, there's always value to supine films as well. So just thoughts for the viewership are that we see a little bit of movement. I completely agree with what Dr. Rajasekaran said about that. But I do think that your surrogate here for a supine lateral X-ray is the supine MRI. Presumably it was a supine position for the MRI. More and more you may be having upright MRIs. I don't know, we have our share, but the most part they're supine. And I think, unless it's the power of suggestion, that there's a more reduction of that slip on the supine study than the upright X-rays. So to me, clinically, she's having these attacks. Obviously, we don't see lytic or erosive changes elsewhere. This is not inflammatory. This is not sacroiliac joint. To me, this is meaningful clinically, even if it's only 2-3 millimeters of absolute change.
Right. So two important points you got about. One is that if the listhesis looks less on an MRI, but more on an X-ray, it's likely to be unstable. And the other is that the data points are not necessarily a take-home message for everyone. And you still want to use all your coordinates before you call this unstable. Just going forward, Ajay, just to stick with you, would you, in such a case, would you have ordered a supine bending X-ray or a standing bending X-ray? And is there a cross differentiation between the two in your book?
The films, so a standard lumbar series for me would have been the same that was done AP, lateral, and then flexion extension. There are times
erect
for
or supine. The question is erect or supine. Would you get flexion extension erect or supine?
Oh, sorry. Flexion extension would be erect, not supine.
Right. Dr. Raja agrees, supine versus erect.
Yeah, in this particular case, it doesn't make such a big difference, but I think on the whole, when you order a series, it's erect, flexion, and extension.
Dr. Hadgaonkar, in any clinical diagnosis, do you specifically ask for a supine bending X-ray?
Supine bending, generally I prefer to get the standing, but not really, I will say. Supine bending very, very less likely.
Right. All right, sure. So going forward, Dr. Rajasekaran, now this is we need to plan her because she's up in the wards for the last few days waiting for you guys to give an opinion before we start planning treatment. So how do you think we should, should we give her blocks or should we just rest her out, give her medications? She's come here for treatment because she's reached the end of the line.
Yeah. So the first decision is conservative or surgical. I don't think there is a big take on conservative treatment here because she's young and this is long-drawn process. It's already 3 years. She has had multiple attacks and it's come to the stage that she has got a hyposthesia and she has also got just not pain. It's also bilateral lower limb claudication. And she needs to get on with her life, and surgery is something that's going to dramatically change her capacity for activities of daily life. So I would discuss this with her and propose a surgery for her. And my favorite treatment, which I do routinely for these cases, is to do a TLIF.
Right.
So
And
I'm a posterior guy. I do most of my surgeries from the posterior, and this is it's a very standard surgery. I mean, it's a L4-5 fusion, and then we do a good thorough decompression, completely take away the disc space. She has got some modic changes over there, but we just take away the disc space, fill it with bone grafts and a cage and a TLIF.
so Dr. Bhojraj was on rounds with us the last week and he ended up seeing the same lady. And he said that he would do a PLF with no interbody work. He's very happy as long as there's a wide decompression. He's not too gung-ho about opening up the foraminal space. What is your take on that form of treatment?
So PLF means with fusion or without fusion?
With fusion, screws, but no interbody, that's all.
Okay. So we started with that kind of treatment a long time ago. So we always did a PLF and this, but for the last, I think maybe 12, 13 years, we are just doing a TLIF because the whole idea of, we did a PLF because we thought if you do a PLIF, then there is an increased chance of intradural work, intradural fibrosis and nerve root injury. All that has been swept under the carpet once TLIF started. I mean, TLIF is quite very simple. It's a straightforward surgery. It has the additional advantage that you can do a very thorough fusion of the anterior column where it needs to fuse. You can restore the height. And I think the incidence of, I can't give you a number, but all our patients are much happier when they have a TLIF in the first few months as they have a PLF.
So did you move to a TLIF because you're unhappy with PLIF?
If I can rephrase the word, our patients are much happier with TLIF. You can easily get them mobilizing, and the incidence of implant failure or need for revision is very, very low after your change to TLIF.
Yes.
Yeah.
Okay,
Sir,
right. So one last question. Yeah, Shailesh.
Yeah, I just want to ask, there are a few centers, they prefer to do an anterior surgery.
Yeah, so I was just coming to that. I was going to ask Ajay that. Ajay, this lady knows you're from North America and she has been reading a bit and she's Googled that in North America, they would offer a small incision operation from the front and a small incision operation from the back, which works much better than Dr. Rajasekaran's alternative. And she really wants us to ask you whether, you'd be happy to go with that versus the standard TLIF and any pros and cons of the procedure.
So I like what Dr. Rajasekaran said. First of all, that in my hands, I would be very comfortable doing that. I totally agree with that. We can talk later about role of interbody, but to focus on what you're saying, straight anterior is preferred by some people based on training experience. There's direct lateral as well, which we can talk about. I don't know if you want to focus on that.
Yeah, I mean, when I meant anterior, she's read about some small holes put in the stomach and you get the listhesis going. So she's not too sure whether we spoke of direct anterior versus the D-lif or the X-lif. It's your call.
So, absolutely. If you did direct anterior, so-called A-lif, anterior lumbar interbody fusion, you could do that standalone with anterior fixation, given the right factors, bone quality, habitus, etc. And then she just has to understand if you're doing just that, but she has remaining radiating pain, she might need a minimally invasive decompression, which works very well. In my hands, I would not do direct anterior, but I would think about lateral, which is still an anterior spine surgery. The ligamentaxis of ALL, PLL, you could get quite a nice reduction, lordosis, interbody fusion, small incision, and then in that same session, back that up with percutaneous screws. She could be home, a day later. So that is a very appealing, minimally invasive option.
So would that be a preferred operation for this lady?
I think the operation proposed by Dr. Rajasekaran is an excellent one. And in my hands, many times I would do that. I would probably present to the patient that there are a couple of ways to do it. If they have a real interest in, and the nuance is that if you just did direct lateral and then percutaneous screws, you're trying to see if the indirect decompression is satisfactory. Patient needs to have the understanding that if it is not, then over time you might need to come back for something like a minimally invasive decompression. I would offer them.
What advantage of the A+P procedure would you present to her, a lady from Pune, versus the one single stage posterior surgery?
Advantage of the A+B is less invasive, which is maybe important early. It's less important later on. I think she would do very well with the standard traditional procedure. But, many times people are trying to distinguish themselves from the surgeon practicing down the street, honestly. And sometimes it's truly beneficial to do, less invasive. If you worry about diabetes, wound healing, that sort of thing, you might say, hey, I'd like to do something that's tissue sparing.
Fantastic. So just one last word from Dr. Rajasekaran before we move on. What is your take on A+P, like a lateral approach followed by a posterior versus a single stage posterior for a one level lytic listhesis?
So I think, Abhay, for a one level lytic listhesis, I think A+B procedure doesn't offer that big an advantage over just TLIF. Now, TLIF has evolved over a period of time. You no longer need to do those big incisions which you used to do before. I mean, you can do what we call as a mini open. You can do a small 3-inch incision, and they heal very well. And this lady requires a good decompression because she has got bilateral claudication. And you can see from the MRI that she has got a foraminal compression on both sides. So I would be quite happy to do a one-stage procedure. Two-stage procedure, it actually accentuates the anesthetic time. It augments the amount of implants that you need to put, the cost of the patient. And to me, every single procedure that you do in spine surgery has a certain number of complications attached to it. So you do 2 procedures instead of 1, you have a certain amount of complication and revision rate associated. I am quite happy to do a single stage, minimally, not 2 big incisions, but do the standard TD for this patient.
Awesome. Great take home, Shailesh. Let's go to the next case. Himanshu will post her for a single level TLIF in the coming week.
Yes. Okay. Thank you, Dr. Nene. It was a very interesting case where we learned from both the masters what really we should do. The next case, adjacent to the same lady, is a 43-year-old female referred by a gynecologist. She was a known case of CA cervix, and she received 4 cycles of chemo. She was in severe pain, inability to sit and stand. She was in terrible pain where she had to lie on her, lie down supine. It is difficult for her to lie down. So she was lying on her prone position. That pain, the pain was that severe. It was an advanced stage uterine CA. Neurologically, there was weakness in the hip. The knee was grade 4, ankle and foot was grade 2. Grade 4 power in all lower limb. No ball and bladder. This was the X-ray, where we can see 5, 4, 3, 2, 1, D12 wedge compression, and these were the blood parameters, where the hemoglobin, the patient was anemic, ESR was raised, alkaline phosphatase was 91. Other parameters were normal, and this was the primary CA cervix, and the MRI was this. This was a metastasis, and now in terrible pain with lower limb weakness, I would like to ask Dr. Rajasekaran.
Yeah. Okay. So I think this the fact that she has neurological deficit and the fact that she has got severe pain actually makes things much simpler for us, because you can use very complicated criteria. There are many scores for how you assess metastasis and all that. But if you have a patient right in front of you who's progressing neurologically, I mean, she's partial. She's not total, but she's partial, and she's progressing and in very severe pain. There is no doubt that irrespective of what is the primary, as a spine surgeon, it behoves on us to provide stability to the spine and also a decompression to the spinal cord. So most probably this is a secondary from the carcinoma cervix. So although there can be surprises when you do a biopsy, but that's extremely rare. So I won't hesitate, because she is otherwise fit for surgery. Her hemoglobin is 8.9, and then all the other, if everything else is okay,
Yes, sir.
I wouldn't be too worried about it. Get a good anesthetic assessment, and I would post her at the earliest possible for posterior decompression initially. So 2 levels up, 2 levels below minimum. So you do a standard stabilization with pedicle screws, and then do an extensive decompression of the spinal cord. That would be the firefighting surgery for her. That would relieve her pain. That would relieve her spinal cord decompression. Then send it for a biopsy. And when you do these procedures, it's important that whatever is you do from behind, you not only decompress posteriorly, not just to decompress the spinal cord, but you should go very well laterally and remove all the tumor tissue from the region of the pedicle and also little beyond, so that when you do an anterior surgery, if it's necessary at a later stage, you will be happy. Oh, you can see, thanks for showing this. That's a very extensive carcinoma. And she definitely needs a tumor completely. You can see that the cord is completely blocked. She would require a complete. So what I mean is, you need to remove all the posterior tumor and also the posterolateral extending beyond the pedicle onto the posterior sides of the body. You should remove from both sides. And that will completely decompress the cord. And then you can take a call. You can take an oncologist's opinion, and then there can be multiple opinions on whether this is tumor sensitive and whether it is followed by just radiation, or you can do that. So you can get a PET scan, everything, but my idea would be that PET scan can be done, but as a surgeon, she requires a stabilization and complete decompression.
So we were posting her for tomorrow, but they said PET scan. So should we wait for a PET scan or just go ahead and post her for tomorrow?
A day is okay, but PET scan is going to give you the information of what is the other metastasis present and what is the longevity. But that is, I think, a part of your long-term staging and planning for treatment. But if I have a patient with severe pain, and if she is partial neurologic and she is progressive, if there is a delay in PET scan, because even if you get a PET scan and whatever be the result of the PET scan, your idea and planning for the tumor is not going to change. If this patient has got a reasonable life expectancy of greater than 6 weeks, I won't hesitate to still go and do the same surgery. So for me, PET scan is something what the oncologist requires to decide on her future.
So we need not wait then. Should we just post her and go ahead?
Yeah, you can post her and go ahead if she's progressing neurologically. even if she is 8 weeks, and that 8 weeks she is bladder and bowel incontinent. I mean, that's going to make her last few weeks really, really bad.
Yeah.
As I say, the last scene of a film is the most important scene. The last chapter of a book is the most important chapter. The last few months of someone's life is the most important period. So that has to be perfectly pain-free, and they have to be bladder and bowel intact. I think that's very important. So I wouldn't hesitate to go ahead and operate.
Okay. I would like to ask Ajay, would you like to discuss with the radiologist whether the tumor is vascular, or would you like to do a embolization, or you will just go ahead and plan for a decompression?
Well, great case, and really appreciate Dr. Rajasekaran's comments. I think the nuances here are, we would just say system-wise, be ready to be part of a team. Obviously, the principles of neurologic and structural stability and lack thereof at present are clearly the priorities of what we want to achieve. Radiologist and embolization specifically, I would say, in my experience, in my training, and my understanding, these are not vascular tumors, but I do think that I would differ from his comments in that there's neurologic instability here, but if it's not rapidly progressive, she's got an incomplete situation, and the ability to respond and improve is still preserved if we fully study her to understand factors like overall tumor burden, perhaps a biopsy, because while the primary is known, we need to, sedimentation rate is increased. Clearly this, this likely not an infection. It's not another tissue type, but it just would help to know. Then we need some guidance about, is our goal resection completely of an oligometastasis plus the primary for long-term survival, or is it palliative? And based on life expectancy, we talk about things like, do you put cement in the anterior column defect or some sort of structural autograft, or where in my setting, I can think about allograft. So all of this is what I would factor in preoperatively.
Perfect. Thank you, Dr. Joshi. And it's always a dilemma, a surgery we always plan, but whether we should consider palliative surgery, decompression and stabilization, or intralesional excision and stabilization, or en bloc. I would like to ask Dr. Rajasekaran's thoughts on this, how you will proceed for this case, sir.
So as I said, the surgical planning for me, I'm not a great enthusiast on en bloc resection and stabilization. So I would do a 2-stage surgery. That 2 stages may be on the same day or maybe staged. But my usual routine is that I do a posterior stabilization. I do a complete decompression from the posterior side. Then the material is sent for biopsy. And if it is vascular at that stage, then we also do an embolization and then come back to an anterior where we do a complete intralesional excision and then stabilization.
Okay. How you will deal with this, Dr. Nene? Abhay?
So I just thought that from me, I would have got a onco team on board and they would have insisted on the PET. So we would not go ahead without a PET scan, mainly because I'm slightly aggressive with an oligometastasis in a young lady. I may consider, getting more tumor out than just palliation. And if not a single stage en bloc, a 2-stage en bloc would be my choice. So I'd do a PET scan. I'd probably even do a biopsy. I'd do an embolization. And then maybe go for a single or a 2-stage en bloc surgery if it's an oligometastasis.
Okay. Yes. Last words, Dr. Joshi.
I think that we can do a tremendous amount from all posteriorly, and I agree that's a great option. I would just say that again, in my setting, with the availability of minimally invasive retractor systems for direct lateral surgery, I would also consider this. The goal here is not saving levels. I like the 2 above and 2 below notion from posteriorly, but if we are going to get a great anterior column reconstruction, the best access and perhaps the best access for the anterior decompression would be starting with lateral thoracotomy, limited thoracotomy, and then posterior as well.
Thank you very much, Dr. Joshi, Dr. Rajasekaran, for your inputs. And now we will really plan, because now we are very clear about how we should go about this case. Over to you, Abhay, for the next case.
Yes, thank you. Next one is is a simpler case. She's a note case. She comes with someone's contact, and she's this young lady who's who's a ex Kathak dancer. Young because she's approximately my age, but she's a Kathak dancer, and last few years she's noticed that she's unable to strike the hand as the foot as well as she used to, only on one side, and she's had progressive weakness of one hand in the more recent times. So if Shailu has finished examining her, we'll move on to her clinical picture. This is how she finds relief when she sits in her house in this position. She says her symptoms seem to settle, and she sent. We've asked her to. We are examining her now, and that's the difference in the hand movements, which intermittently changes. Like on some occasions, the hand functions much better. But what is of note is that her left side, upper limb and lower limb, is completely normal. And is this keeping with a spine case, Dr. Rajasekaran? Do you think it's spine, or do you think it's CNS?
So what's her plantar like?
There are no upper motor signs in the limbs.
Because you said that she's also got progressive incoordination in the right leg.
That's a symptom. There are no signs
So,
from
because
slightly brisker jerks on the right, but no upgoing plantar for sure.
So, because they are all on the right side. And has she got a Hoffman or some other signs?
No, negative.
Oh, negative. It's just a progressive weakness.
Yeah.
So it's both in the upper limb and the lower limb. So it's obviously not outside the spine. It's not a brachial plexus or a peripheral nerve lesion. It's in the central nervous system. So it has to be a unilateral lesion, means it has to be really a high level lesion. Or also, as you said, it could be in the cranium. I would be not hesitating to do a very thorough imaging system for her after more examination. It could be both. I need to do both.
Right. So she's someone got an MRI for her. It didn't look that impressive. The brain was reported normal. And what is stark, Ajay, is the lack of pain. She's not talking of pain as much, and the overwhelming symptoms in the hand rather than the arm. What are you thinking now? You have primary imaging available. The brain has been reported normal. Do you think we should take her up? Do you think we should go with some more studies or get some references from other consultants?
I think the cervical spine does not stand out as having obvious focal compression. You think about things like peripheral neuropathy, demyelinating syndromes, and saying that this is likely to be multiple sclerosis. But I feel a little in the dark, and honestly wouldn't hesitate to get a neurology colleague to do some heavy lifting and further investigation.
Right. So I think an important takeaway. Yes, Dr. Rajasekaran.
One of the things is, can you show, do you have a close-up picture? Is there any signs of demyelination or?
Actually, none. I would be able to blow this up, but there's no sign. There's no cord sign. There's no cord signal change.
No signal intensity change over any length of the cervical spine or anything like that?
No.
Okay. None. I think we should be really, really careful, get a neurologist opinion and not hurry.
Yeah.
What was the
I think it's an important insight from both our panelists that if there's lack of pain, no true radiculopathy, no true upper motor signs, overwhelmingly hand symptoms, and even though the MRI reports multi-level disc and compression, clearly if the mind's eye tells you that this compression is not significant, most of us would think that. So we had her go through the motions, and she on inquiry says there is occasional vertigo, and she clearly says that when she rests off, her symptoms are much better compared to when she's flexing her neck and working. And we had a neurologist also see her. Actually, her gait was also mildly hemiplegic. We had an EMG NCV done, which turned out normal. We had a contrast MRI for the brain, which turned out normal. And the neurologist put her hands up and said that, this seems all is good from my side. And the neurologist read the report of the saying multiple disc bulges and said, "You please go and operate." The ball is back in your court, sir.
So what do you mean by gait was hemiplegic?
So she walked with that, a longer stance phase on one side, that kind of a gait, rather than a spastic gait.
Yeah, I mean, there are 2 or 3 issues over here. The neurological clinical signs are very vague. I wouldn't be, it's not allowing me to pinpoint to one etiology or the other. Secondly, if you add the radiology to the clinical side, then we are always talking of clinico-radiological correlation. So you need to have a hard clinical diagnosis, or at least 1 or 2 differential diagnoses on the clinical side, which you feel very convinced about. And that has to be corroborated with a radiological diagnosis and also a radiological level. So in the absence of both of these, I mean, I would be very hesitant to actually put my knife on her.
So what should we tell her now? Should we just pack her off, or
just
should we?
Tell her exactly what we think about. Say that she has got some neurological problem, but right now we are not 100% sure of what exactly it is, and we are not confident that surgery will do her good.
Right, perfect. Ajay, she's asking if there are any more investigations that could help us nail the diagnosis, because she's been through this cycle once a year for the last 3 years, that she comes in and then, everyone just backs off.
I don't see any obvious additional investigations. I would just echo that there's not a surgery that we think could help her, but that if it's delivered in the context of, caring about her status and outcome, following her periodically, these days in the current climate we're in, for many people, we're just trying to remind them about mindfulness and stress management, and that may have some value, rehabilitation strategies, and expectant management for now.
So, I mean, this is what our first poster did before, just when she got admitted, and we didn't actually ask for this X-ray, but this was done. Does this say anything, something more about this, or you still want to bat her off, Dr. Rajasekaran?
No, it obviously shows that, what is that, C2, 3, 4. That is some amount of C4, 5 instability over there. I mean, there is some amount of subluxation. I also was talking to you about the notching or the sliding off of the anterior part of it. You can see over there, which means that C4, there is a small subluxation over C5.
Chronic subluxation, isn't it?
Yeah. So, that is the syndrome which is just not getting. And we had a case of this even a few weeks ago, which is typically unilateral. And what is that syndrome?
Cervicogenic unilateral syndrome, isn't it?
No. It has got a. It's a very. I mean, it just slips my mind. I can just.
But what's the narrative on the syndrome?
It's very typical. I mean, there is a small subluxation or an instability. It can be on one region. There is a mild kyphosis. So there is a draping of the cervical cord over the neck bones. And their neurological symptoms are usually unilateral.
Right.
I'll just come back to you. I'm just giving a call to Ajay because
to know the name. Ajay, the question here is that this is the area in question. You can see the flattening out of the cord here, and you can see the same area is unstable. Clearly, there's a translation also. And we've done all the investigations on the side, and we've kind of reached no conclusion there. And she is disabled. It's been over 3 years. At this point, would you like to take her up, or would you think it's irresponsible to offer surgery at this point?
No, that changes things. It's an important illustration.
Yeah, okay. Abhay, I got that this thing. I just text Ajay and he gave. It's called the Hirayama's disease. This
Okay.
is very, very typical of Hirayama's disease. I mean, just that we discussed this a few weeks ago, it should have come to my mind initially. So this is very typical. So these are, this lady is a little bit older for this. It usually occurs in the second or third decade. There is a mild cervical kyphosis. So the anterior part of the cervical cord, which has the anterior tracts, gets draped and stretched over the cervical kyphosis. There can be typically a single level subluxation. And so this is very positional. If she lies down and then has her head in extension, you can see that in the position of the extension, the subluxation actually reduces.
Yeah.
And so they get better with this position. And what is very typical and diagnostic of it is that the neurological deficits and signs and symptoms are one side. We don't know why it happens, but it is always unilateral. And these patients do well with a single level fusion. So this is
given that,
or you can even actually do cervical fusion. It is good. It's called Hirayama's disease.
Right. So Ajay, you were saying, does this change your plan? We don't want to bat her anymore and you want to take her up?
Yeah, certainly. I think that this is, straightforward now. It makes sense. It speaks to this imaging is understating what's going on. And so I don't know if upright MRIs, I'm not saying they're routinely indicated, but that would have been a nice correlation here. But, very telling on the film. And if just for the viewership, I tell patients that it's as if this person had a 2-level cervical fusion, C5 to 7. And this is really a situation of adjacent segment disease is the way to think of it. Single level surgery is fine. The not dilemma, but the question becomes, while you're there, you see spondylosis at C3-4. We see C2-3 rarely break down above a multi-level posterior or anterior, but C3-4 is at some risk. And if you think there's any neurology correlating with C5-6, C6-7, it's worth addressing it while you're there. Clearly C4-5 is
what would be your plan for surgery? So now that we're going to offer her surgery, what surgery?
ACDF C4-5, and I would probably decompress C5-6, C6. I would think hard about doing C3-4. I don't see obvious segmental instability there, but I see the disc degenerated. So I probably would leave C3-4 alone. 3-level ACDF would be my plan.
So that's 4-5, 5-6, and 6-7 discectomies and interbody fusions, no corpectomy.
No corpectomy, discectomy, a very good central and foraminal decompression, and interbody fusions, correct.
All right. So the question echoes back to you, Raja, that would you prefer anterior versus posterior? And if anterior, would you like to take away bone and put a single graft to have less areas of fusion compared to multiple grafts and multiple small operations?
So Abhay, this lady gets actually the disease. The other name for this disease is flexion compressive myelopathy. So Hirayama's disease is called as flexion compressive myelopathy, and the patient does very well when they are holding their neck in extension. So there is no need for us to do a corpectomy. So if you can recreate the extension of the spine, and then you can make that good by doing a multi-level ACDF, that's fine. So I don't think there is a need to do a corpectomy. There is no harm in doing a corpectomy, but the same results can be got by doing a 2 or 3 level ACDF.
Any role of posterior surgery?
It's not necessary here because it's a flexion compressive myelopathy. This patient gets a problem only when they get into a kyphosis.
Right.
So if you put that kyphosis at that level, I don't think that's going to be a problem.
Right.
So it's actually a perfect case for Hirayama's disease.
Great. Awesome. A lot of learning points from that case. Thank you, gentlemen. Shailesh, your case?
Yeah. From this interesting cervical case, now we go to a 62-year male farmer was operated elsewhere twice for lumbar spine and comes to us with rolling weakness. There was one side foot drop completely right sided, and the left side was 4 by 5 in ankle. Previous surgery was L3 to 5, and this was the incision, and this is how he was walking, and this is what the X-ray with lumbar kyphosis, 3 level, 3, 4, 4, 5, 5, 1, 2, 3, 3, 4, 4, 5. This is the AP X-ray. This is the whole spine scout film, and this is the MRI. Would like to ask Rajasekaran sir. Severe pain. Now this pain is worsened in last 6 weeks, and operating.
Sorry, just remind me again. He has been operated
Twice.
twice.
Yeah, twice.
And what were those surgeries?
First surgery was no details available, but only decompression discectomy at 1 or 2 level, and second was laminectomy multi. See that around L3 to L5 laminectomy was done, undercutting L2.
Okay, can you show the sagittal MRI? Okay, this, just wait a minute. So obviously this patient has got a very degenerative spine, not a big scoliotic element, but it's got a multi-level degenerative spine, multi-level rectolisthesis, instability, and on attempted extension, there are vacuum signs at 4 or 5 levels. So this is a patient with gross degeneration, gross instability, and also multi-level compression, spinal canal compression. And also he has got complete loss of lumbar lordosis and alteration of all the pelvic parameter. He's slightly decompensated. And so he requires his, if he is in severe pain and because there is a lot of compression at multiple levels, I mean, there is a little place for giving an epidural or some favored nerve root blocks if you are not keen for surgery, or if he is not fit for surgery, or the general condition doesn't allow so. But I think on the long term, if they are looking at a permanent benefit for him, I would advise surgery. Again, I am more in favor of, in my practice, we do more commonly posterior surgery. So the aims of the posterior surgery would be to restitute his lumbar lordosis and the sagittal parameters. And that would be by also do a thorough decompression. He may need some facetectomies, complete removal of the discs, and recreation of the lordosis by restituting the disc space, lordotic cages inserted, careful contouring of the rods, cobalt chromium rods. And probably he will require, because the MRI is supine, so it looks quite good above L1. But if you looked at the flexion extension views of the X-rays, I think there was a lot of instability going up, a lot of retrolisthesis and other degenerate changes happening even at the thoracolumbar level. So probably I would do a long fusion and multi-level cage decompression and cages, surely at L5S1, L4-5, L3, L2-3, and decompressions up to 5-4-3-2. Yeah, 2-3, 3-4, 4-5, and L5S1. So those would be the levels I would decompress, and also probably do a TLIF.
Okay. What about you, Ajaya?
So thought process before getting to a surgical plan is, nutritionally robust, bone density is okay, pretty miserable and struggling, and reasonable surgical candidate. I would offer him really a great option in my hands has been direct lateral and complete anterior longitudinal ligament release for hyperlordotic implants. So if you did, and the key question, I'm so glad that you put up these pelvic parameters, Shailesh, because the question is, how much do you need? And planning that is important. So if you thought of this as a 2-day operation or same day, both are reasonable and viable. With previous work in the canal, my concern about extensive work like pedicle subtraction is you're working around scarred dura, multiple levels. So what I would really lean towards here is saying that in your 50s, you don't need for your lumbar lordosis to match your pelvic incidence. You maybe want to come within 15 degrees short. So you're looking at for an additional 20, 25 degrees here. You can achieve that with multiple interbodies and Smith-Peterson osteotomies. You can also look at hyperlordotic implant at one or more levels. For example, L2-3, L3-4, that's a direct lateral, retroperitoneal, retrorenal, through the psoas, you need the nerve monitoring. That's, reasonable and standard in my setting. And then either done for the day and come back, or same day you do L2 to S1. You think about pelvic fixation as a backup, thorough decompression, discectomies. Looked like the worst stenosis was L2-3. And then certainly for a construct like that, you'd want interbody support through a PLIF or TLIF at L5-S1.
Yes, Dr. Nene, what will you do? Is CT scan important for you in this?
No, I would not do a CT scan. I just go ahead and do a long posterior with multiple interbodies, mainly because I'm not so conversant with the direct lateral, but I think that's a great option here. It can, make the morbidity of the surgery much less if you do multiple anteriors first and then do a posterior, as against the last case, which was a single level. But I'm curious to know, I know it's a ward round, but Shailesh, I'm sure you've operated this person already.
Yeah, he was in bad pain and the relatives were very keen. Therefore, we were planning to wait, but we had... we had very...
Why were you planning to wait?
We did, as Dr. Rajasekaran just told us, the same plan. We did a multi-level fixation and decompression at 3 levels and interbody at 3, 4, 4, 5, and 5, 1. 3-level decompression, deformity correction, and we got... this sometime back this was operated.
Ajay, can you spell out your advantages of your procedure versus this one? Shailesh, can you go back to the post-op X-ray?
So, go on.
Yeah, no, that's nice work there. I like that. The advantages, if you did something like an L1-2 looked like it was possibly breaking down, I would not think too hard about incorporating it. But I've been very impressed with the power of the ALL release and the ability to gain segmental lordosis in 1 or 2 segments. So I think the advantages are more sagittal correction in fewer segments. The disadvantages are, repositioning and 2-part surgery. So that's how I would summarize that.
So you've practically gone away from this operation for this clinical scenario?
Yeah, I haven't, because I know being in the back is important. We need to address the stenosis, and I think it's a very reasonable way to approach things. It's not that so if someone has a history of anterior surgery, or their build or their habitus is concerning, there are times where you would say, just accomplish everything from the back anyway. But my only concern here would be, is this enough lordosis? So I'm curious if there's consideration of either pedicle subtraction, which is maybe more than needed, or Smith-Peterson's that can be very effective. Looks like that was done here.
So without being diplomatic, do you think this guy will come back soon because the lordosis is not adequate and he's a farmer, a heavy loaded back?
If he's going to continue to load his back, I think the concerns are just, this may do very well. I would just tell the audience that that pelvic fixation, especially with the S2 alar iliac technique, perhaps unilateral, is a way that maybe that's treating the surgeon, not the patient, but that's a way to sleep better. And if you have a construct of 4 or 5 segments or more, I will routinely do that at least on one side, and then 5-1 inner body, just because that segment worries me. That's the only constructive points I would raise with.
Raja, what would you do different here?
Yeah, just echoing Ajay's thought process. The only thing we can find comment to is that his lordosis restitution is not sufficient. So there are other this is a long segment fusion in a heavy worker. So I would be very particular, because if you're just thinking of S1 pedicle screws to support the entire long segment fusion, then the chances that you may have a failure of your lowermost fixation, a break of the rod, or a break of the screw of S1 is more common. So S2 alar screws are much more safer. You can get a much better fixation. You can use larger screws, longer screws, and they are more biomechanically stable. So that's certainly one thing that we would have done. Second is, if you're using TLIF or a PLIF at multiple levels, then it's mandatory that your lower segment L5S1 must have an interbody fusion. So not to have an interbody fusion at L5S1 and to depend on S1 screw alone, those two are a little weak points which may lead to implant failure. So as Ajay said, if you're doing only a posterior fixation, then probably you need to really take care to use as much bigger cages as possible, distract as much as possible, try to get your maximum lordosis at L5S1, L45, and L34 level. So these are the points.
Points well taken, sir. Thank you for a great discussion on this case. We did not put a cage at 5-1, but we did a bone graft at that level. But yes, point is we should use the cage, and S2 AI or S2 screw is useful in this to prevent any issue. Thank you. We will go to the next case. Over to you, Dr. Nene.
So again, this is our next. The lady is lying in the next bed, and she's been sent here for surgery from a local GP, from a local orthopod. Now this is her. I don't know if you're able to see all the elements there. 62 is wrong. She's 42. Progressive back pain for the last 3 months, and otherwise she's functionally okay. She's walking around, but because of the back pain, she got an X-ray done. And she's bending well when we checked her. Now she's just admitted here because she's been referred because her X-ray showed this, and it showed there was spondylodiscitis clearly at one place, and this is how the MRI looked. And the local orthopod panicked and told her that she needs urgent spine surgery referral, and she's come here, for management because she's been told that she's going to go off her feet very soon. Ajay, what would you do with this, landed up in Texas?
Well, so hyperreflexia, but otherwise neurologically ambulatory and 5 out of 5 strength. Is that right?
Yeah, you can see her bending down to touch her toes.
Okay. So then start with the biopsy and, see what's growing. I confess I don't have the ready experience with the TB, the TB or pot spine toolbox. But if this is some sort of fungal or bacterial problem, then we're looking at, would want a CT to assess structural stability, and potentially it's antibiotics if it's a very treatable organism looking for resolution. There is an epidural component, so likely that surgery will play a role as well, and likely that it's laminectomy, and then the extent of anterior work probably needs a CT scan for my preoperative planning.
Right. So chemo or surgery or everything?
Well, I would want an organism first because again, the algorithms for Pott's spine, I don't have readily at my fingertips, but by chemo, do you mean standard antibiotics?
I mean, because we don't know the bug, we need not presume it's tuberculosis. We don't know the bug. It's just a spondylodiscitis. So
Right.
any any medication for the infection. That's what I meant. Chemotherapy for the infection.
Well, certainly a biopsy first to see what it is, to guide what is likely to be antibiotic therapy long-term, regardless of, so biopsy first, and then are you asking, is there a role for antibiotics and bracing alone and no surgery?
Right. That's right.
Potentially. I mean, there's some literature now indicating that an infection with an epidural abscess component, neurologically stable patient can respond. There's quite a bit of stenosis here, so I would have to say we would watch her carefully. Again, if there's structural stability and an infectious disease consultant feels like antibiotics can make a good difference, I would at least try that first with a brace.
Right. Raja, do you think differently here?
Yeah, I think there are two parts to this question. How conservative can you be? If that is the question, then I would say that technically and academically, if you can just get, I mean, this MRI-wise definitely looks like Cox spine.
Why do you say that?
Yeah, because there is a lot of bone destruction and the pattern in which there is cold abscess and large amount of paravertebral mass, a large epidural abscess covering between two vertebral bodies going all the way, the size and shape of it, and in presence of such a big epidural abscess, there is not so much of cord edema and cord compression. So this is
suggesting a slow indulating kind of
slow indurating granulating mass. Yeah. And you can also see within the cold abscess that the epidural granulation mass, you can see multiple signal intensities. It's a part of granulation tissue, part of abscess, part of sequester, all put together. It's very typical. I mean, so I would actually bet that it is most probably Cox. Although, I mean, all of us know from our practice, you can get surprises from time to time. So if you'd say, is there a role for conservative therapy? If somebody is not confident of surgery, there is no support for surgical services, then I have no hesitancy to say that this is eminently treatable conservatively, because if you look at the X-rays, radiographs, I mean, it's not as bad as, it's not as frightening as the MRI. There is no instability, there is no spine at risk signs. The superior affected body is snugly coming and landing on the inferior body. There is no tilt, there is no translation in the AP. So this is still in the stable part of the disease. And so if you do a transpedicular biopsy, you can get some tissue for histopathology, also send it for gene expert, confirm the drug sensitivity. I'm sure that this patient can be treated by conservative method. So no doubt about this. But in my actual practice, that if you get a case like this where the patient has, the patient is bending so much forward, so I'm not sure whether she is in a lot of back pain. So probably it's only
she's not in a lot of back pain.
Yeah, not in a lot of back pain. This hyperreflexia is a very soft neurological sign. So it's really a very, very gray zone. If she had some spasticity or a neurological deficit, or a lot of back pain, or one or two radiological signs positive for instability, then I won't hesitate to operate.
I mean, here we are in a situation which is so common of a chronic disease like tuberculosis, where the MRI is very bad, but the patient is, ridiculously good. Yeah, so in this situation, what would you...
they can...
We are in Sancheti Hospital, so we have everything available with us. We have everything. The best surgeon, and we have all the material, biopsies, the best chemotherapy guys, everything.
Yeah, this is treatable conservative. Especially because you have shown a clinical picture where the patient is bending forwards much more than what I can normally do. So it just shows a very stable spine. and she has got no back pain, and she has got only mild hyperreflexia. So this is treatable conservatively, but in actual, I mean, this is treatable conservatively, but my threshold for operating on this is very low. I would actually prefer to decompress the spine because she has got hyperreflexia, then fix 2 levels above, 2 levels below, remove the epidural mass, free the spinal cord completely, and then do a posterolateral approach, transfacetectomy, excise the facet there, and then, part of the body is already destroyed, so the disease itself has shortened the spine. So the actual gap in the anterior column you get when you do these surgeries, you find that they are much lesser than what you normally see. So the gap that you will get there is about 10 millimeters or a little more or less. So that can be easily have an anterior column stabilization by the use of a cage. I mean, that would be my best approach.
Yeah.
So that's how we should counsel her now. We'll of course ask the boss, Dr. Hadgaonkar, because it's under him. I just had a question. Would you go Ajaya's way and do a biopsy first and step back and wait for more input before you jump in with surgery, or would you just do everything at one go, Dr. Rajasekaran?
No, I would do everything in one go because I'm almost sure that it is TB spine. But if it is a pyogenic, then all the more important that you need to hurry into a surgery. TB is optional, but if it's a pyogenic with so much of epidural abscess, you definitely need to operate because these patients can have a precipitous neurological deficit anytime. So, but
both our panelists, both our experts are veered towards surgery. Yes, Dr. Hadgaonkar?
Yeah, I just want to ask Dr. Rajasekaran, if the patient goes to Dr. Rajasekaran and Dr. Bojraj, and they tell that patient we can conserve, do biopsy and see, if the patient worsens, patients are okay because they are getting treated by the best doctors. But what about someone who is new into practice and this patient worsens?
Yeah, if the person worsens, then you have a problem on your hand. And one fortunate thing with tuberculosis is they don't dramatically worsen.
Okay.
And that's the reason I said if this is a chance to be pyogenic, then I would not hesitate to operate. And in fact, in one of our teaching sessions a few days back, we were just making it a point. If you suspect pyogenic, then there is whatever time of the day, probably with an epidural abscess, pyogenic epidural abscess, because at this level of the cord, they can have a precipitous neurological deficit. And the neurological deficit you get out of pyogenic abscess is unpredictable in recovery. Whereas in cold abscess, you get a neurological deficit. These tuberculosis patients have a much higher propensity for good recovery. So, if you
the
think
question would go right back to the surgeons, that Dr. Hadgaonkar, what are the chances that you'll worsen her during your surgery? Because you're going to go around the cord. What if she wakes up with a deficit? Someone who's so functionally fine.
There are chances of worsening, but if you use a safety approach as spoken by Dr. Rajasekaran, you go from the facet side, do anterior debridement and decompression. There are good chances that you will not have a...
No, I mean, it's clearly a higher end surgery. And if you're talking of the new surgeon in practice, he runs the same risk either way.
Yeah.
So what would you do? Yes, Ajay.
I think it's also important to keep in mind, I think we all share an orthopedic background. Information and thresholds change over time. It used to be a mantra that was ingrained in us that open fracture, you needed to get into the operating room within 6 hours for extremity trauma. And these days, an injury from 10 p.m. gets treated as the first case in the OT the next day. It used to be a mantra that you had to do 3 liters of fluid. And so I think now, we start questioning some things. So I think the operative comments are reasonable, but people should realize there's a significant potential morbidity with surgery. For example, doing an adequate anterior column reconstruction. And then what you do find when you deal with infection or tumor is from behind is that nerve roots are pushed dorsally and they can be hard to distinguish. So a tear of a nerve root with this anatomy and with infection present, that can be potentially a very bad situation. So just being mindful that you are looking to work promptly, but precipitous decline is possible. But I still think I would take a little while, monitor her, admit her if needed, and we do have some time to work with.
Fantastic. So that's a good balance. Shailesh, can we show the next case?
Yeah. The 21-year-old male comes to the clinic, and this is what the deformity is. We can see there is some old healed sinus or scar in the thoracolumbar region, and this is the deformity. Not been able to lie on his back, always lie on his lateral side, and somehow managed to get finances to get this surgery done, which he was waiting for a long time, is come from other state, first time to us. And this is the X-ray, severe thoracic kyphosis, 110 degrees, hump, convex cob is 65 degrees. I would like to ask the man who has described this entity worldwide, Dr. Rajasekaran, sir.
So, Sailesh, this is a segmentation defect from T9 to T12 with a kyphosis of 110 degrees. And also, if you look at the the AP view, naturally is not so clear because of this. It looks that there is not only a kyphosis, but there is a slight, the two segments, the superior and the inferior segments of the spine. Can you just show me the 3D X-ray, 3D CT scan? Yeah. So there is a gross kyphosis. Okay. So the next thing to ask is why did he delay, and what is the reason that he has come for treatment after such a long delay?
No, because he is from a small town in periphery of India, and he was unsure about the surgery, and with recent advances where he looked up on the internet and development in surgery where this surgery is possible, the family
he learned about Sailesh and then he came.
Not really, but
No, the reason I was asking is it that he has got an increased pain suddenly that he came, or there is a neurological deficit that has started that he came?
Yes, there was a subtle weakness, but no deficit, sir. I will say one leg was only grade 4, but it was very partial. He could walk, no deficit major, and mild pain, lumbar spine.
Okay. Does he have any cardiorespiratory problems, respiratory especially? What did he have? Any?
Yeah, his lungs, his chest was reasonably okay. We took opinion of the chest specialist, PFTs, all were okay.
Okay.
MRI also was showing only the deformation and segmental anomaly at these levels, but no compression per se at all the levels.
Okay. Right. So he has got a very severe congenital deformity, probably a hemivertebra or a kyphotic vertebra, or the posterior incarcerated hemivertebras, maybe at 1 or 2 levels is quite difficult to see over in the small pictures. So that is surely, what is the apex of the deformity, Sailesh?
It was D12.
So D12.
D11, D12.
Okay. So we are going to have the conus and the cord, all these stretched over the apex of the curve.
Yeah.
And typically, if the patient comes with a sudden onset of pain, that's the reason that I asked that, because many of these patients can suddenly decompensate even when they are going into the adult level.
Yeah.
They will have a 10 or 15 degrees increase in deformity because one of the facets gives way and then it starts paining a lot. And that's the stage when if you ignore them, then they also get neurological deficits slowly and progressive over a period of time. So this patient, if he has got no pain and if he has got no neurological deficit, then you really need to be really careful in your surgical approach because you are having a young guy who's walking without much problems, and you need to be really careful that at the end of the surgical procedure, he is not worse off than what he is now. Now, you need a lot of counseling for him. You need to explain the surgery. You need to really be transparent and candid with him on the pros and cons of surgery. And if he understands that and accepts that, now for the last few years, we are going into the procedure of having them on a walking halo, mobile halo system. That will be there for about 4 weeks. And we find a lot of benefit in this. You know, we have recently published a classification system also on this kyphosis, and this typically would be 3C, which means that there is a anterior column defect and a posterior column insufficiency, because in many of these, you can even see very clearly on the far lateral pictures of the 3D lower down that the facet joints dislocate and there is a posterior column insufficiency. So because of the defects of these two columns totally, and if it is more than 60 degrees, then they slowly get into this pattern of collapse, which is called the buckling collapse. Now, in these patients, they can have a little bit of restrictive pulmonary disease, and that increases the morbidity post-operative. So if you put them on a walking halo for some time, you will find that their lungs improve quite a lot. Their digestion and their gastric capacity improves quite a lot. Within the 4 weeks, they improve in weight by 5 or 6 kg. Their single breath count increases from about 12 or 14 to sometimes even up to 40. They are much fitter, more nutritionally balanced. And you will have an improvement in this kyphosis of about 20 degrees. It's just not that improvement in 20 degrees, but also it makes that part of the segments which are included in the compensatory curves more mobile. And that makes it very good for surgery. So we will do these preoperative preparations of that takes a few weeks. You need to tell these patients you have had this deformity for many years, and so you need to be patient for these few weeks. And you know, within the first 1 or 2 weeks, the patient feels so much better by himself. Their lung capacity increases, their digestion capacity increases. They feel that they are putting on some weight, and they feel very positive towards approaching the surgery. The surgical technique itself is, you know, you have this is probably incarcerated congenital kyphotic vertebra, so that you need to excise the vertebra. Make sure that you have at least 4 or 5 segments included in your fixation above and below. And then you need to very safely do the procedure. That technique has been very well described. So you do the anterior wedging, make sure that you do a osteotomy, and you should not close, but you should use an adequate, because if you just close, then you shorten the spinal cord so much that the anterior spinal artery kinks and you can get a neurological deficit. So you should not only close, but you should also open it on the anterior side. What size cage you use, how much you use, depends upon how much of corpectomy you had to do in the front. And then you'll have to do it very carefully. So I would like to emphasize that our results have gotten much, much better after we had these patients in Halo for a few weeks. So we learned it from Boachi. So when I visited his place in Ghana, I was pleasantly surprised to see nearly 30 people at the same time on a Halo. Previously, whenever we used the Halo, we were doing the mistake of just having them on the Halo for 10 or 20 days. Professor Boachi used to come to Ghana once, put them all in the Halo, and he used to return back to US and come back after 3 months, by which time they are all corrected quite a lot. Even the most stiffest congenital deformities loosened up quite a lot. And when he came here to our unit as a visiting professor, we again learned that from him. And I would strongly advise this preoperative preparation before the surgery. If there's anything particular in the surgical technique that you want me to say, I can say about.
So we just want to know because sometimes we have heard you describing putting the fibula, keeping the deformity as it is, and decompressing.
Okay, that is for actually, suppose you have a patient who has got a very stiff spine, and the patient comes actually only for pain. So we get a lot of these patients who have come for pain, and when you explain to them the complications possible in the surgery, then they are very, very hesitant. And one of the things that you can do is in these patients, what we call as the salvage surgery, is you put them on the halo, you open this up by about 10 or 20 degrees, and then you can see that the upper segment and the lower segment has been horizontalized. And there are two vertebral bodies facing each other. So you can put two fibular stud grafts in front of them and then hitch it onto them and put a screw also on the fibula to the body. And these patients, if they are not worried about their deformity, they are so much better off. Their pain is gone and they are quite comfortable. But that's a salvage surgery when for some reason you do or the patient doesn't want to take the risk of a big procedure.
Okay. What about you, Ajaya? How will you deal with this?
I would say I would just listen to Dr. Rajasekaran. It's not the first time I've just sat and listened and learned, and that was beautifully said. I agree completely with the value of the halo gravity traction. I've used that more with kids, but totally makes sense here for adults. And the things I think that are of value to think about are, does your system allow for complexity? The tools that I have available include navigation. Not that you need navigation for these screws, but it can be very helpful. Nerve monitoring, which may be a conversation that, again, is very setting specific. That would be not just for litigation and risk management purposes, but for executing a surgery and knowing when a correction was safe. I don't recall the latest about how routinely available that is in your settings, but these are things that people should think about. Do they have nutritional support, pulmonary, plastic surgery, a team, and the adequate resources? Otherwise, in terms of the thinking, the execution, I think it was beautifully stated by Dr. Rajasekaran.
Yes, I think fantastic rundown by the boss himself. But young Shah Rukh Khan, what did you do? Can you tell us? Because this is again an interesting case.
Yeah, we gave the pre-op physiotherapy and chest rehab for getting a better compliance. We did not use the halo, but that's a big learning from Dr. Rajasekaran. And as we planned for a deformity correction, posterior approach all throughout, and 3-level PVCR was done. We used this piezo surgery device, which was additional for that segment which was there. And if you see, it was a completely fused 3 levels, 4 levels, and that saw really helped us for decortication and debulking. And we were really scared. We used the neuro monitoring, and it was very difficult to get the reduction. But luckily, we used the cages as described, and anterior support multi-level releases and osteotomies. And this is what the correction we got at the end.
Looks fantastic. I wanted a tip from Dr. Rajasekaran that everyone wants to know is that when you finally correct such a 120 degree kyphosis, how do you minimize the hit on the cord? Like, is there any good way of or slowing down the pace at which you're correcting the kyphosis, or are there any tips on your sleeve?
So you have to do it slowly. Gradually. So you should not hurry. You should be all the time remembering that you're playing with somebody else's spinal cord. And you have to do it slowly. It's just, and also you need to have a very good control. If you're using a cantilevering type of maneuver, you need to have a very good control of the rod and the systems. And Ajay said that you need to have a neuro monitoring that's absolutely mandatory. Then we have navigation, so that makes it a little bit easier for us. But one of the other things that you really require is a very good anesthetist who would keep a hypotensive anesthesia in the stages of the dissection, that when a hypotensive anesthesia is permissible to reduce the blood loss. And also when you have started to manipulate the cord and to do the reductions to keep the blood pressure to a safe 90 millimeters and above, but not going above 100 degrees. But the fourth important component for all these surgeries, which is very important, is a skilled and trained assistant, a person who knows what is happening and what is expected out of him when you're reducing, and how he is holding on to the rods and how he helps it in the reduction. So I think very important thing which sometimes we should not forget is to have an assistant who knows what is happening and how he is going to help you with the surgery.
Yeah, but all this done, sir, at the end when you're doing the correction, it's you and the cord. Like everything pales away. So is there any method of really slowing or making this less risky, the final correction? Do you use alternating rods? Do you use in situ bending? Is there anything you can tell us?
Ajay, it's a mixture of everything. So you need to have the alternative rod technique. And then at the end of it, you also compress and do a mild inside to rod correction. All of these.
Right. Lovely case, Shailesh. Anything you want to add, Ajay?
Congratulations for this good job. It looks really good.
Thank you, sir.
Yeah, good job.
Thank you, sir.
Lovely.
We go to the next case, Dr. Mene.
Yeah. Much simpler day-to-day problem. Again, this guy, he's the neighbor of the lady we saw. And he's come with, a similar complaint, but this time there's a lancinating pain. There's no deficit at all. His history is a long-standing history of multiple episodes of pain. Each time they've throttled him down, given him medications, rested him. A couple of times he's taken a shot in the neck. Each time it's just pain. There's no deficit. And his work is now getting affected. And because he's the last lady's neighbor, he's come to us already with a flexion X-ray, because he was told that the last time they, after they saw this X-ray, they realized what's going on. So he's come with this X-ray. And as you can see, there's nothing much going on there. But clearly, it's the MRI that, is diagnostic here. So just moving forward, this guy again has come for, as he calls it, a permanent solution, because he's been through a lot. Ajay, what are your initial thoughts for him?
Initial thoughts are he has been through conservative care. He has persistent symptoms. Obviously you start with all the conservative things when they have not been done. In this situation, I would check the facets, but assuming no facet arthropathy on a CT scan, excellent candidate for a disc arthroplasty. Very reasonable, even when there's kyphosis, which I don't see his neutral lateral, but appropriate even in kyphotic patients, appropriate even when there's cord compression. This is a soft disc causing compression, so I think you could do excellent decompression and still have a satisfactory bony end plate status for your implant, which these days the studies show not just non-inferiority, but superiority for 1 and 2 level disc replacements for longevity, reoperation, satisfaction, etc.
So just to pick your brains there, that's the chronicity of the symptom. So this is going on for the last 3 years. at all make you feel that this could be a calcified disc, which becomes a poorer indication for a arthroplasty compared to a fusion?
It could be calcified, and that's where I would check the CT scan, certainly.
Right. So you would not make a final plan without a CT here.
Never plan for arthroplasty without a CT to check the facets and for that disc status.
Right. Dr. Rajasekaran, any difference of opinion here?
Yeah, nothing to the contrary what Ajay said, but in my practice, it would be a single level ACDF with a standalone cage. So I think in a single level disc, I mean, there's nothing much. I think the surgery here that the patient really wants, or the surgical part of the procedure, if I should say that actually that the patient is begging, is the removal of the disc and decompression of the nerve root. If you have done that very well, I don't think there's going to be a big difference whether you do a ACDF and whether you use, how you fill the gap is much secondary. I don't think it influences the outcome as much as how well you have decompressed the nerve root. So once you have done that part very well, whether you use a tricortical graft or a single level cage, or you use the cage and the plate, I think cage and the plate is definitely inferior to the other two. But my preference would be a standalone single level cage.
So if I push you to answering this question, that should a mobile interface be better than a fixed interface?
Yeah, in the literature, you have things to support both. I mean, if you love replacement, of course, there is a lot of literature which says that a single level replacement is better. But if you're not keen off with it, there is also again tons of literature which says that there is no major difference. It depends upon whether you're a Catholic or Protestant.
So you truly don't believe that a mobile interface will make a big difference?
I truly don't believe that it makes a big difference because, yeah.
Right. In the blue corner, Ajay, do you have anything to say here?
I think that the literature, the more we study this, the single level, 2-level studies, the more we're seeing that farther and farther out there is superiority for the disc arthroplasty. But the single level ACDF, fusion, and in my hands, I will choose machined allograft bone. Again, that's readily available. I think it's an excellent biologic structural allograft. But I have no problem with the single level ACDF. That's been a tried and true solution in my hands for years and years as well. But sophisticated patients doing internet research will come to you and do point out rightly that there are some advantages to disc replacement. And I think, like the examples earlier, resolving those differences will get clearer the more we follow these cohorts over time.
Yeah, so can you briefly tell us what is the advantage of a disc replacement? Is it an immediate result, or is it the lack of adjacent segment degeneration? What is your mind thinking?
That's a great question. I see them recover more quickly to where they're returning to work and resuming normal activities much more quickly. And admittedly, my single level construct is not a standalone. It's got an anterior plate, so that may affect oral pharyngeal function, and that's sort of apples to oranges. But it's early recovery, return to work, return to activities, and then it's certainly what you said downstream, which is avoiding adjacent segment issues above and below.
So actually, I agree with Ajay on the fact that it's very important what you are comparing with. So if you are comparing with a single level replacement with a plating, so I do think that that's two things which you should not compare. Because if you use a cage or whatever you use as a space filler and then you use a plate, then there are definitely issues, and there are literature to show that use of plate is associated with plate-related complications. But if you use a single level standalone cage, then the disadvantages of using the plate having been removed, then the differences become completely narrowed down quite a lot. So you need to be really very careful when you use a single level disc replacement. You should take all the precautions, choose the cases carefully so that there is no spontaneous fusion, which in that case becomes an expensive method of fusing. And if you're not very accurately placing the cage, if you're not looking at the exact placement, if there is even a mild amount of eccentric placement, either on the anteroposterior side or on the lateral side to what each of these specific makes do, then you're adding an eccentricity to your flexion extension, and that has its own level of problems. So in a single level, I think this patient is 56.
Yeah, 50.
Yeah, I don't think, no, there is no harm in just using a single level disc replacement. I mean, absolutely, there is no disadvantage. But I would like to also emphasize for the young surgeons who are listening to this that a single level standalone cage is pretty good.
Thanks. Shailesh, before you start your case, which is probably going to be the last one because it's 8:15, can you tell us what you would do? Or if you were the patient and Raja was a surgeon, what would you ask Raja to do for you?
No, probably I will go for a fusion.
Right. Okay. Go ahead with your possibly the last case, Shailesh, 8:15.
Yeah, we will just scroll through the last 1-2 cases. We are getting a lot of questions, but they are getting answered by both Dr. Rajasekaran and Dr. Ajaya. This is a young 16-year-old boy, 10 days worsening with weakness in the hip and
No, now you can see out.
So he's got a myelopathic gait.
yes, and short history, sudden weakness, lower limbs, and this is the X-ray, and this is the MR. Hyperreflexic.
Yeah, okay. So, Sailesh,
Yes, sir.
this is what is the level? T7?
E8.
T8, okay. So can you just, even this picture is quite good. I mean, it's because it's very classically, radiologically diagnosable. So this is a lesion in a young male thoracic region, involves the body extending onto the pedicle, and it is extending onto the posterior structures, collapsing the anterior segments and expanding the posterior structures with multiple fluid levels is a diagnostic of aneurysmal bone cyst. So of course, as I always say, you can always have surprises, but you can fairly be sure that this is an aneurysmal bone cyst. The MRI picture is very, very classic.
Yes, Ajaya, any input from you?
Agree that it looks like that's what it is, and it's obviously leading to neurologic symptoms. There's likely integrity of a rim of right-sided D8, but the priorities are decompression and bone grafting, interlesional or marginal resection, and then bone grafting, including some sort of strut support on the left side would be reasonable. Maybe with fixation one level above, one level below.
What will you do, Dr. Nene?
I was curious to ask Dr. Rajasekaran, why not giant cell tumor?
These kind of multiple level fluid levels are characteristic of aneurysmal bone cyst. I mean, there is a very rare type of variant of the giant cell called the aneurysmal cystic giant cell, but this is too classical. So I would think it's aneurysmal bone cyst.
Because just again to pick on this point, would that not make a huge difference in your treatment plan, ABC versus GCT?
Yeah. No, but yeah. So anyway, this needs to be, he has got a cord compression, he has got a myelopathy. So probably you are asking this question to lead to another question. Will you just do a biopsy and then wait, or do a PET and all this? But I don't think all that is required here.
Okay.
I would, because he has got a neurological deficit, if you're fairly sure of that is the only lesion, then I would assume it's an aneurysmal bone cyst and then operate.
So my question was actually angling differently, that if it was an ABC, what would be your surgery? And if it's a GCT, what would be your surgery?
So if it's an ABC, my surgery will be 2 levels above and 2 levels below posterior fixation. And then at the same time, these aneurysmal bone cysts are not so vascular, and they don't give such a big bleeding complication as a giant cell can do. So here embolization is optional. So I would do a posterior surgery first, 2 levels above, 2 levels below, do a complete posterior decompression. And as I told before, I would decompress the cord also on the lateral side and slightly on the anterior side, removing all the bone of the pedicles and up to the bone cortex junction. And in this case, because he is quite young, maybe we can actually do a good removal of this if there is no much bleeding from the posterior side itself.
So intralesional, is it? Will it be an intralesional surgery, like curating out?
Intralesional surgery.
Yeah. So,
and in the GCT, it would differ, right?
Yeah, in the GC, but if you go in the front, the back, when you go, you will already know that what it is.
Yeah, as there are free fluid levels, as sir said, it's most likely ABC. And what about using cement anteriorly, Dr. Rajasekaran? Will you use in this?
No, I will not use cement for what, Shailesh?
For reconstruction anteriorly?
No. This guy is a 14-year-old guy, so I would like to have some sort of bony reconstruction then.
Okay.
So preferred was, of course, to have a cage with a lot of bone grafts inside.
What about you, Ajay?
The defect is amenable to something structural. So I know that structural allograft is not typically available. So I don't know if these days you're still thinking about structural segments of iliac crest or something, but I think the cage is a reasonable option. It's taking a morselized mass of bone and asking it to fuse, which it will in a healthy 16-year-old, but I would do something structural if possible on that left side after the wide decompression that we've discussed. 1 level above, 1 level below, probably.
Okay.
So you want to tell us what turned out, Shailesh?
Yeah, this patient, as he was young, he came to my colleague, Dr. Ajay Kothari, and then he took a couple of opinions. Again, he came back to us, and we both planned for a decompression, and we did the posterior decompression as Dr. Rajasekaran just told us, and we luckily we have this recent O-arm navigation where we could exactly delineate the complete tumor, and we decompressed it completely, front and back, all through posterior approach. This is the intraoperative video and the image, and this is the final picture. If you see, we put a lot of bone graft anteriorly, almost up to the posterior cortex, and we fixed 2 above, 2 below. It was quite a stable spine when we fixed.
And histology, finally?
It came out to be an aneurysmal bone cyst. And luckily, there was no worsening, and is rather improved very quickly post-operatively.
Right. Would Raja have done something different here? So I'm alluding to the morselized graft versus doing end plate to end plate reconstruction.
We would have used either structural graft, iliac crest graft, or I would have used a cage.
Ajay?
Agree with that.
Right.
Okay, that's
right.
That's
so fantastic case, Shailesh. Do you want to? I think we should roll down now.
Yeah, we have a last and then we are done.
So you go ahead.
Yeah, just a quick case.
It's been great learning, guys. You guys have brought on the table a lot of points that were not even, floating in our minds. And I'm sure the audience has taken a lot away from this. So, thank you. I can't thank you enough for sparing so much time on a Saturday morning for you, Ajay, and Saturday evening party for Raja.
Yeah. This is a 60-year-old patient, comes with elsewhere operated lumbar spine with increasing counts.
You want to share your screen, Shaila?
Oh, it's not shared, sorry.
So for the benefit of all the audience, Shailesh, can I ask what is all the gold medals behind you?
Sir, they are all the cycling and running medals, not for any other use.
Shailesh here is a multifaceted guy and he does lots of things outside the magic he does in the OR.
That's all I learned from you guys. This is a 60-year-old man with low back and difficulty to stand. Elsewhere operated 4 to S1 T-leaf with broken implant and increasing counts, WBC, ESR and CRP. There is lumbosacral infective focus, if you see that, and the patient is in terrible pain. Yes, Dr. Rajasekaran.
Okay, can you show me the X-rays?
The S1 screw is broken.
Okay, so you say that the S1 screw is broken on both sides. I can't see it properly. One side or both sides?
Yeah. I just enlarge.
Yeah, bigger. Make it bigger. Okay.
Can we see now? Yeah.
Yeah. All right. So he has got broken screw. I think it's only just one screw. I'm not sure which one.
Yes, sir.
On the lateral view, yeah, I can see a broken screw.
And there is a big
L4 screws seem to be all right. L3 screws seem to be all right. There are 2 banana cages. The L5, the lower one is slightly now digging into the bone. And it's always very helpful if you can have an X-ray, immediate preoperative, post-operative X-ray to verify the position of the cage. Because if the cage has migrated or if the cage has sunk inside the bone, then obviously there is no doubt that it is infected. It adds to your suspicion that that could be an infection. But I think here there is a MRI corroboration of an infective lesion. Problem over there. There is also some fluid and it's extruding into the epidural space from the disc space. So I think now we can consider it as infected discitis with a metal cage inside and a broken screw over there. So this is a situation that would warrant debridement. So I think we can take blood culture or a needle biopsy for this, but I would, in my practice, go straight, revise these implants, completely debride the disc space, carefully remove the cage, and then the options of what I would do with the S1 screw can be you can recite the direction, or we have the navigation, so that will allow us to do if the broken screw part is not able to be removed. Or we now have the broken screw sets through which you can remove and then put in another. Or if you want to have your screw farther away from the site of infection, then you can use the S2 or screws 2. So once you have completely debrided, then you will have to look at whether the end plates are still intact or the end plates are completely gone. And we have actually published a paper before on that you can still do a fusion straight away in infected places, but here it is a patient in whom we do not know the. Do we know what is the organism inside Saidish?
No, sir. No.
No, in that case, then I would probably play safe with just using, we can shorten the bone at that. And if we find that the S1 and the L5 are coming very close together, then I would use antibiotic loaded morselized bone chips. If there is a lot of pus inside, I think it's a pan tissue infection. Then I would also have the other alternative of putting some cement beads inside and coming back after fixing.
Sir, there is.
Right away, on the first time, I wouldn't be tempted to use a vac. So I would still go for a closure. So that would be, but most of my decisions would be intraoperative.
Okay. Sir, will you do anything to the L3? If you see there is a large opening at L3, and I just want to just tell this is a patient who is a lady. Sorry for that. There is some wrong print, but she's a lady of 60 years old. Will you do anything for L3 screw, sir? L3, whether you'll add up because you are anyway going for this.
So if I might, what I would say is, sorry, this is a conversation with her about, again, medical fitness, about multiple stages. And the reason is CT scan clearly for bony information. I think these cages and access would be very difficult from the back given previous surgery. I would look at collaborating with a skilled vascular surgeon for anterior access. I like the notion of pulling the cages out, debriding cement balls with antibiotic impregnated on a string, maybe for 4 or 5 days or a week, and before there's scarring, coming back with structural allograft. Structural graft, probably iliac crest for L4-5, L5-S1. Then you turn your attention to the reconstruction aspect, which is, yes, L3-4 looks like it's about to fall apart. And for her overall long-term outcome, she looks like she'd benefit from hyperlordotic. Again, you could do that from direct lateral at another stage. So now we're on stage 3 if the two anteriors were 1 and 2. And then you look at a final stage 4, which is posterior revision, L3 to probably pelvic fixation through the S2 alar or redirecting S1 screws, and then not having to do much from posteriorly at L4-5, L5-S1 because you've already managed that from anteriorly.
Yeah, I mean, that's a safe approach, but there is also the practical issues of doing a 4-stage surgery on patients in this part of the world. So I think the good compromise, I think putting into practice all the principles which Ajay elucidated. So we need to think of one, stability, good debridement, and anterior anterior reconstruction.
How many weeks antibiotics, Dr. Rajasekaran?
After this, I would, it depends upon what is the organism also.
Assuming it's the common MRSA organism in hospital acquired.
Yeah. So I would give at least 2 weeks of intravenous antibiotics followed by 4 weeks of oral antibiotics.
And do you do any repeat imaging, or is there any, after the antibiotics are over, is there any follow-up that you would do?
Nowadays, we are depending a lot on imaging to assess what's going on inside. Not only for spinal tuberculosis to close your chemotherapy, but also in these cases, if they are symptomatic, especially if they are symptomatic. If the response is not as good as what you think it should be, then we depend a lot on not only ESR and CRP and those kind of biochemical investigations, but we also depend a lot on your radiological investigation. But then you should have a radiologist who is specially trained and who are used to seeing a lot of post-operative MRIs. Otherwise, they can also confuse you a lot.
Right, right. Anything you want to add, Ajay, to that?
I think that's well said.
Yeah, fantastic. So, Shailesh, anything else you did differently?
No, I think completely agreeable what they said.
Right, right. Awesome. So over to you. Back to you to call it a day.
Thank Thank you very much, Dr. Rajasekaran. I know sir for the last 16, 17 years, and every time I meet sir, I learn something new. And today was no different. And we all know why he is a legendary figure. The way he thinks, it's a great learning for all of us, I'm sure. Thank you for spending a big time with us, and looking forward to see you, sir, soon. At the same time, I would
Thank you for inviting me. Yeah.
Thank you, sir. At the same time, our dear friend, Dr. Ajay Doshi, who is always there for these kind of academic meetings and spending time with us. Ajay is known for his work on Vector. And we really appreciate giving time on a weekend. This is early morning for you, Ajay, there. Thank you very much for giving us time. At the same time, Maharashtra Orthopaedic Association, Dr. Shinde sir, Pune Orthopaedic Society, Dr. Karne sir, OrthoTV, and Dr. Ashok Sham. Their support is incredible for this kind of webinar and grand rounds for the benefit of all of us. We thank all of you once again from bottom of our heart, myself and Dr. Abhay Nene, who is a great support for this initiative. We sign off and see you soon. Thank you very much. Thank you once again.
Thank you, Abhay. Thank you, Sailesh. Ajay, it was seeing you for a long time. Bye-bye.
My pleasure and privilege. Thank you very much. Be safe. Take
Bye.
care.
Dr. Shinde, sir, bye-bye to you also. It was good seeing you also. Ashok, Himanshu, all of you. Bye-bye.
Thank you, sir. See you.
Thank you, Iman.
Bye bye, sir.
Thank you very much, sir.
Thank you, Shinde sir. Thank you, Ashok.